Okay, welcome everybody. Again, I'm Sarah Jewell. I'm the Assistant Director of Clinical Services at the Myra Mahan Patient Resource Center, and I'm introducing Dr. Kerri Aronson today. Her career is dedicated to the care of patients with interstitial lung disease and pulmonary fibrosis. She is an expert in patient-centered outcomes in ILD, focusing on defining and elevating outcome measures for clinical practice and clinical trials that are most meaningful to patients. Dr. Aronson is developing a patient-reported outcome that measures quality of life in patients with chronic hypersensitivity, uh, pneumonitis, CHP, to better define, understand, and address the challenges associated with antigen identification and avoidance in patients with CHP. And this seminar will provide an overview of pulmonary fibrosis, including its causes, how it is diagnosed, common symptoms, and both medication and non-medication approaches to treatment. And it will also cover some of the ongoing research for treatment. So I'll turn it over to you, Dr. Aronson. Oh, I think,
Hey,
yeah.
great. Thank you so much. Yeah, I just had to unmute. A wonderful. Thank you for that introduction. Thank you so much for having me. This is a great resource center. It's really wonderful that you have put this together. And I'm so glad to be a part of giving the talk today. So thank you all for joining. And for those of you listening on later, I hope you can learn something from me today. So I'm going to focus on just what was spoken about. These are my disclosure slides, several grants, and then I do a little bit of consulting. Overview, I'm going to talk a little bit about today what is interstitial lung disease and what is pulmonary fibrosis, and we'll kind of delineate the two and how they fit together because sometimes that can be a little bit confusing. We'll talk about the common symptoms of this disease. We'll talk about how we diagnose, how we treat, and talk a little bit about what progression means and how we look for that. So I always show this slide to our trainees because interstitial lung disease can be very confusing. When you're learning it as a medical student and a resident and a training doctor, there's a lot of different diseases that have different acronyms, like you can see here, and it can be very confusing. What is what? How do I put it into different categories? What does that even mean? How do I treat it? And so it can be sometimes an alphabet soup, and that can be confusing for us, and it can also be confusing for our patients. And so I'm going to try to do my best to distill this down. We won't go through every single one in detail, but just to give you a general idea of how we categorize these things and think about them. And the main ones that we'll focus on today are the big group of interstitial lung disease, and then I'll talk about pulmonary fibrosis and how that fits into the grouping of interstitial lung diseases. So what are interstitial lung diseases? It's a group of lung diseases that are really come from about 200 or greater different types of causes. And you can see this sort of big circle here. It talks about all lung diseases. So we've maybe heard of things like asthma or COPD, chronic obstructive pulmonary disease. And interstitial lung disease is just one bucket of all these different lung diseases that is separate from those lung diseases. And within interstitial lung disease, a grouping of those can develop scarring in the lungs, and we call that pulmonary fibrosis. So here's another figure just explaining that a little bit more. So we have our grouping of interstitial lung diseases from a variety of different causes, and not all of them necessarily involve lung scarring. But when it does involve lung scarring, that's when we say pulmonary fibrosis. So you can have an interstitial lung disease that does not have lung scarring, and therefore you do not have pulmonary fibrosis. But when your interstitial lung disease involves scarring in the lungs, that is where we get the term pulmonary fibrosis. So interstitial lung disease results from, like I said, inflammation and or scarring in the lung tissue that surrounds the air sacs of the lungs. So hopefully you can see my cursor here. And the way I like to explain the lungs is we have this big tree, right? These are the airways. I call that the tree and the branches of the tree. So when you take a deep breath in, the air goes through your mouth into your trachea, which is the long sort of trunk of the tree, and then out into various parts of the lung through these different branches. And the interstitium, or the area that's involved in interstitial lung disease, is basically like the leaves off of those branches. And we call that the alveoli. And what the alveoli are these sacs that contain the air that you breathe in. way out into the distance of the lungs. And in between those air sacs, there's tissue, and that's the interstitium. And so all of those areas have tissue and have airways, which is the tree branches that go into them. And there's also blood vessels that surround that, so that when you breathe in the oxygen from the outside, the oxygen is able to get into the rest of your body through the blood vessels that are in the lungs and then carried to the rest of the body. And this is another schematic sort of showing the alveoli, right? So we have the bronchioles, which are these branches, and then the alveoli, which are surrounded by the interstitium. And if you can imagine, when you want to have an area that creates a pathway for oxygen to flow out and something like carbon dioxide for us to blow out back into the air to exchange with each other, you want to have a good pathway to do that. And when you get inflammation and scarring in that area, it can prevent that exchange from happening well. So this shows another sort of schematic of that, and this in a different way, in a closer view, right? So I mentioned inflammation and or scarring in the air sacs and the tissue that surrounds the air sacs in the lungs, right? And so you have a healthy lung, and as you can imagine, you breathe air in, and we breathe air in, we get oxygen, and the oxygen comes into these air sacs, and then it gets transferred through these blood vessels out into the rest of the body. And then when the body uses up the oxygen, it makes something called carbon dioxide, and that gets blown back out into the air through our lungs. So that exchange happens there. Well, if you have scarring and you have damage in those areas and inflammation and injury, it can disrupt that process. And so that can happen with inflammation, and it can happen with scarring or pulmonary fibrosis. So this just shows that another example of that. So there's a lot of different causes of inflammation and scarring in the lungs. And so that can lead to different types of interstitial lung disease. And when we're evaluating a person in the office to try to better understand what's causing the interstitial lung disease, as we take our history and we do our exam and we get blood work, which we'll talk about a little bit more, we're thinking about these different causes and if one of them could be at play with each individual patient. So things like medication someone might have been exposed to, if someone's had radiation for example, cancer therapy, radiation to the chest. Environmental exposures are a big thing we think about. Things like mold, birds, feathers, farming, and a whole variety of list of hundreds of things that we can think about for environmental exposures. Autoimmune disease, some people may have heard of as a cause for interstitial lung disease. These autoimmune diseases often affect multiple organs in the body, and the lungs tend to be one of them as well in some cases. And we see interstitial lung disease in that case. Different jobs or occupations sort of goes hand in hand with the environment, but an environment that somebody has worked in, so coal mining, asbestos exposure, things like silica. And then sometimes we can never identify a cause. And so when we can't identify a cause, we tend to call that something called idiopathic. So something like idiopathic pulmonary fibrosis, which is a common type of interstitial lung disease that some people may have heard of. And other times we call it unclassifiable or idiopathic, meaning that we don't know what the cause was. And so these are just some examples of more of the common causes that we think about. And what can happen over time is with many interstitial lung diseases, you can start off with inflammation and injury that then turns into scarring. And you can imagine when you have a cut or, you have an injury to your skin and you see a scar that forms afterwards, oftentimes that scar doesn't completely resolve. And that's what we end up seeing in the lungs. And over time, in a subset of these interstitial lung diseases, we can see progressive pulmonary fibrosis. So scarring that progresses over time. And I will talk a little bit more about later on in the talk as well. And it can be hard to upfront really identify how long that progression can take. It can happen over many years, and we see that where we have patients who we identify a small amount of scarring, maybe 10 or 12 years prior, and then we see that progress slowly over time. And then other people, that progression can happen much quicker. And there's a lot of research right now to help identify the risk factors for who it happens quicker in and who it may happen more slowly in. And something that's very, very important to all of our patients are that the symptoms that are accompanied with interstitial lung disease. So we talked a little bit about the mechanisms and what it may look like in the lungs, but how is this impacting people, right? And so that's incredibly important. And so the symptoms can come in a variety of different combinations. Things people more commonly complain of are things like difficulty breathing or shortness of breath, cough, fatigue or low energy that's sort of separate from feeling short of breath, just feeling very worn out and tired. Stress and changes in mood. Sometimes this can be accompanied by weight loss as well. And these are just examples. It's certainly not an exhaustive list, but some of the examples of the more common causes that we see or common symptoms we see. And we know that interstitial lung disease and pulmonary fibrosis can have a substantial impact on a person's quality of life for some of the reasons I already mentioned, right? The symptoms that people may experience, and then that can spill over into different types of social participation or how it may affect somebody's job or the impact on your family or caregiver, independence, different other types of comorbidities. And when we say comorbidities, that's other medical conditions that people may have that sort of are at play with the interstitial lung disease. And you can see a variety of things here that we think about can impact people who are living with interstitial lung disease. And so it's really important as pulmonologists that we are always trying to make, number one, a correct diagnosis of does this person have interstitial lung disease or not? And then if so, what is the type, right, or the cause? I showed you that a couple of slides ago of the different things that we go through and we think about what could be causing this interstitial lung disease. And it's really important because it helps us with a conversation about what might be the appropriate treatment what can somebody expect in terms of monitoring and the disease course in the future. And so when we see a patient for the first time, and when I see a patient for the first time in my interstitial lung disease practice, there's a lot of things that I will ask, and there's a lot of testing that I will have, and some people may have experienced this. So we'll take a pretty thorough medical history, asking about other medical problems, medications someone might be exposed to. Family history is incredibly important, as well as what someone's occupation or other exposures might be in their home life and their job or other areas. We will do an exam, a physical exam, listen to the lungs, see if there's any findings of any autoimmune disease on the exam. Sometimes we may be clued in that could be the cause. And then we will take a slew of blood work that looks for different markers of autoimmune, or we call it rheumatologic or connective tissue disease. You may have heard of some of these words thrown around, and other labs that may look for exposures. And then certainly we care very much about radiology, right? We look at the CAT scan, and it's often a CAT scan is the gold standard right now. So CT scan of the lungs for looking at the pattern of the lung disease, because that can help sometimes clue us into what the cause is. And then sometimes, but not all the time, we will look at pathology. Not everybody gets a biopsy. It's not necessary in every case, but in some cases, people will have a procedure where lung tissue will be taken in order to look at that under the microscope and help that with the diagnosis. And then once we've taken all that information and put it together, we come up with our best working clinical diagnosis. Really, what is the cause of this ILD or pulmonary fibrosis? And then we talk about what might be the right treatment for somebody. And we'll talk about later on in slides, how we could come to that determination. But it's not just about medications. We also think about if we did identify any potential exposures in somebody's environment, we want to make sure that we're counseling people on how to remove those exposures and recognizing that there are often challenges with that. And then, of course, we think about treatment of conditions or other medical problems that might be associated with the interstitial lung disease, whether it be an autoimmune condition or something such as gastric reflux, which may be precipitating symptoms associated with the interstitial lung disease. And we really do our best to try to come with a consensus about what the cause is for the interstitial lung disease. We do this using a multidisciplinary approach. So we have scheduled meetings pretty much every week, sometimes twice a week, to discuss our new cases and ongoing cases of people that we're caring for who have pulmonary fibrosis or interstitial lung disease. And as a group, we will meet always with the radiologist, sometimes with the pathologist, which read the biopsies. So if there's a biopsy, and other times will involve there's other specialists like a rheumatologist if it's an autoimmune or connective tissue disease. Sometimes we'll discuss with the interventionalists, so the people that would do a procedure if we think a biopsy is needed. And so different people are together in these conferences, and there's often more than one pulmonologist that cares for ILD, plus these other specialists. And we sit and we go over the cases, and we try to come to a consensus about what we think the cause is, and decide, do we need to recommend a biopsy for more information or not? So there's a lot of things that we will discuss. And these multidisciplinary discussions are incredibly important. So you can see on the right side of the screen here, this is just an example of how doing this in our practice really can change our confidence in what a diagnosis is. So this top line here that says ILD-NOS, the NOS stands for not otherwise specified. So basically ILD, but we don't really know what the cause is. So this is one study that looked at the use of this multidisciplinary type of approach to help with diagnosis. And you can see that before having that meeting, this group of patients that they looked at in the study, 41% of them, it was an NOS. And then at the end, everybody was put into a category. Now, I don't want to be fooled and say that all the time that we have certainty about what the cause is, because in a number of these patients, in about 21%, this still remain unclassified. But in 20% of those patients, we were able to help put that into a category to help with treatment. I will say that uncertainty sometimes still can remain after doing all of this. And it doesn't mean that we cannot still come up with a management plan for that. And we do continue to follow people very closely. So the treatment plans, I alluded to this already a little bit. These for ILD and pulmonary fibrosis are very individualized, and they depend on a lot of factors. So we'll talk about some of the treatments that do exist, but it depends on, number one, what the type of ILD is. And then we think about a lot of other things. So what is the lung function, right? So people may have had a pulmonary function test or lung function or breathing test, right? So what is somebody's lung function? That may go into us thinking about how we're going to treat. What is the burden of the symptoms? We talked about some of what those symptoms possibly could be. What is the risk of side effects of these medications? Very important to talk about that. And then also, how do those interact with medicines people may be on for other health problems, and how may it impact people's other health problems? And then, of course, a very large piece of this is, what is the patient's preference given all of these considerations and the risks and benefits of different treatment approaches? What is your preference as a patient for these treatment approaches? So all of that we take into account as we're deciding treatment plans. And this definitely doesn't need to be memorized. I just want to give an idea for, many of our lung diseases, interstitial lung diseases, there's not guidelines for kind of what to do first, second, third. But oftentimes we will have an approach that's sort of agreed upon among experts. And so different buckets of interstitial lung disease, we may start off differently with medication, different approaches to medication, whether it's some anti-inflammatory medicine or a medicine that works on the scarring, like an antifibrotic. And I'll talk about those a little bit more. If it's somebody that we think has an environmental exposure, that could be the reason, whether it's mold in the home is very common here in New York City, or a pet bird, for example, or something at work. We counsel and talk about ways to try to consider first identifying what the extent of the exposure and where it is, and then avoiding that. And so we talk about medicine, and then we also talk about non-medication treatments, which I'll get into in a little bit as well. So antifibrotic medications. So some people may have heard about these medicines. So these are medicines that work on the scarring process in the lungs. So remember, I had said that interstitial lung disease is a combination of inflammation and or scarring, the scarring being the group of people that have pulmonary fibrosis. And antifibrotic medicines were first studied in one type of interstitial lung disease called idiopathic pulmonary fibrosis. That's essentially pulmonary fibrosis without an identified one specific cause, and usually has a certain pattern on CAT scan and other characteristics that help us to make that diagnosis. Now that was the first entity or disease entity in interstitial lung disease where antifibrotic medications were studied. And what we found, there were two different medicines, this medication called nintedanib and another one called pirfenidone. In both of the studies that were done for each of those medicines, what they did was they did a randomized controlled trial, which is the most rigorous type of clinical trial you can do. And they took a group of patients with idiopathic pulmonary fibrosis and gave half of them the medicine and half of them a placebo or, a sugar pill, and followed over time. What they found was in the group of people who were given the antifibrotic medicine, they found that the disease progression slowed over time, looking at the marker of lung function. So the forced vital capacity, this is the lung function you could see here on the left. That's when you have to take a deep breath in and blow out in the lung function test. That forced vital capacity number is the number that they looked at. And what they found was in the people who were given the medicine, there was a 50% reduction in the rate of decline over time. So if you look here, here's healthy aging lung. Okay, we all lose some lung function every year over time. Here is idiopathic pulmonary fibrosis, which is an accelerated rate of decline with progressive scarring. And then with the medication, you can see here, this green line, some lessening in the rate of decline. So did not stop the decline and did not reverse, but we do have medications now that can slow disease progression. So two medicines that were approved for treatment in idiopathic pulmonary fibrosis. These medicines have now, since they've been studied in idiopathic pulmonary fibrosis, have been studied in other types of interstitial lung disease that have progressive scarring, so progressive pulmonary fibrosis. And one main study here on the left was looking at this medication nintedanib. I'm sorry, I should have used the brand name. Maybe some people have heard of this as OFEV. So this was studied in people who have pulmonary fibrosis from other causes that are not idiopathic. And they found essentially the same thing in that group of patients when they studied in a randomized controlled fashion. That lessened the rate of decline in lung function. And pirfenidone, we also have some data, although the study wasn't, these studies weren't as large because some of them were conducted during COVID times and it was hard to recruit for some of these studies. But we do have some data that we were able to gather for some of these clinical trials that showed there was also a reduction in the rate of decline using pirfenidone as well. Another medicine I just want to talk about, so just to take a step back, I've spoken briefly about the antifibrotic medicines, which we have. I very briefly talked about immune suppressing medicines, and the reason I didn't talk about a lot, or anti-inflammatory medicines, the reason I didn't talk about that a lot is because there's a lot of them that are used for different reasons, and it's very individualized. But I definitely wanted to show some of the data on the antifibrotics. And then I also wanted to show this because one of the things that I mentioned was, you can have complications from having interstitial lung disease. And what can happen to some patients is when you have chronically low oxygen levels in the lungs, that can increase pressures in the arteries that connect the lungs and the right side of the heart. And that's called pulmonary hypertension. And so more recently, this medication, which is an inhaled medicine, was studied and approved for people who have pulmonary hypertension and interstitial lung disease. And why this is important is the pulmonary hypertension can also contribute to some of the symptoms that we were speaking about. And what they found in patients who were in this trial was that there was an improvement in the 6-minute walk distance, which some people may have done before in the office, right? In the amount of meters walked compared to the people who were not given the medication. So sometimes we think about this medicine in our patients, not everybody qualifies for it. It's not the right medication for everyone, but for a certain group of people, we may think about referral to consider this medicine if somebody has pulmonary hypertension. So I talked about this, we could have a whole talk just on treatments. So I wanted to keep it to some of the main highlights. But regardless of a decision about medications, all people, we believe, should be offered comprehensive supportive care, right? And so there's much more that goes into caring for people who have interstitial lung disease and pulmonary fibrosis than just medication. While that is a very big part of it, we also know that there are other things that people are dealing with, experiencing. And so in addition to medicines, which is here on the lower right-hand side, we think about other things like supplemental oxygen, which I'll have a slide on if somebody may qualify for that and how that may help with symptoms. Pulmonary rehabilitation or exercise program, and I'll talk a little bit about that. Education, what we're doing right now is so important. And I believe, and a lot of my research has shown that we need more of this psychological support, because there may be physical manifestations of having the interstitial lung disease, but we also understand that this can really impact somebody's mental well-being. Um, Things like palliation of symptoms and palliative care, and end of life care when somebody may have end stage pulmonary fibrosis. These are all very important things that we talk about with our patients. And certainly the discussion of symptom relief, and sometimes we'll even talk about involving a doctor who specializes in symptom relief, a palliative care specialist. One of the symptoms that I wanted to touch briefly on here when we're talking about comprehensive care is that cough can be a big problem for people who have interstitial lung disease. And the cough is very challenging for pulmonologists to treat, regardless if somebody has interstitial lung disease or not, because cough can be caused by a variety of different things. And so, for example, in somebody who has a cough, if anybody in this, here has experienced a cough, you may notice that we're asking other questions that may not be related to the lung disease. One of the big things that we think about are if the cough could be coming from the lungs, could be coming from the upper airway, where sometimes cough can be generated. Cough could become from gastroesophageal reflux, right, or acid reflux, or other problems with the gastrointestinal system. That's a big thing in interstitial lung disease. We see a lot. Cough can also be caused by some of our medicines and the side effect of some medications that we give people either for lung disease or for other comorbidities or other medical conditions. So there's a lot of different things that we will think about, and that's why lots of questions may be asked when we're trying to figure out the cause of somebody's cough. And so I briefly mentioned oxygen. I just want to take a step back. And so what does oxygen do for people? And there hasn't been a lot of research on oxygen, but there has been some. And there's a really, really big push to understand more about, how does oxygen help people with interstitial lung disease? When is the right time to prescribe it? And then also, how can we get better equipment, and help people to manage some of the challenges associated with having oxygen? And so there's a big group of people in the interstitial lung disease field very interested in this. There's actually an oxygen working group through the American Thoracic Society, which I like to tell my patients. People are really working on this and working on some legislation as well to help improve oxygen access for people with interstitial lung disease and other chronic pulmonary conditions. So what do we know about oxygen? Well, there was this one study that was done a couple of years ago called the AMBOX study, where they looked at people with fibrotic interstitial lung disease, which essentially is pulmonary fibrosis, another word for the same thing. And they looked at people who were given oxygen with walking and who weren't. And they looked at things like how their shortness of breath was, their ability to walk. And what they found was the people that reported improvement in breathlessness and walking ability when was improved when given oxygen in that group of people. And so we do find that in our patients and in a lot of patients, the use of oxygen, either with exercise or with the pulmonary rehab or with walking, can really help to improve the sensation of breathlessness with walking and also ability to walk further and function better when somebody qualifies for that oxygen. Another thing that I mentioned is pulmonary rehabilitation. This is exceptionally important, and we bring it up with all of our patients. It's not a medication, but an exercise rehab program that is targeting the people with chronic lung conditions, and in particular interstitial lung disease and pulmonary fibrosis, can have an immediate benefit on things like quality of life, shortness of breath, and physical functioning. And so these exercise programs we have, all over the city here and, and of course, other places across the country. Different access in different areas, of course, can vary. But when somebody is able to participate in a pulmonary rehab program, they often are going twice a week. For at least 12 weeks, and often have a program of exercise that is tailored to their individual needs in a monitored setting. And this helps with endurance, and also there often is education component associated with the pulmonary rehab. And this can help, like I said, improve quality of life and functioning. So we talk about it with a lot of our patients who have interstitial lung disease and who are suffering from symptoms. Okay, so taking a kind of step forward, how do we monitor people, right? I talked a little bit about the diagnosis. I talked about some of the treatments, whether medicine or not medicine. Now, how are we monitoring our patients who have interstitial lung disease and pulmonary fibrosis? So Very important that we follow people closely in the clinic. So, we want to see people, even if I don't have anybody on a medicine, right? Even if we're just monitoring off of medication, we will still see our people at intervals that are tailored to the individual. It may be every 3 months, every 6 months. Some people, it may be every year. But oftentimes it's more, it can be closer to the every 3 to 6 months, depending on what the treatment plan is. We're doing lung function testing to monitor the lung function. We're also doing a 6-minute walk test sometimes, not every visit, but sometimes to see how far are people able to walk, what are their oxygen levels when they're walking. CT scans we will do at varying intervals. It depends on the cause of the lung disease and what we're monitoring, but your doctor may suggest a CT scan at a different time interval depending on the individual situation. And then we're always evaluating, as I mentioned, for other conditions that are associated with pulmonary fibrosis. So I have this echocardiogram written here. So that is an ultrasound of the heart that looks for those elevated pressures in the arteries that connect the heart and the lungs that I spoke about. So you may wonder, why is my doctor getting this? And that's why, we're looking for that. And we're also asking questions about other associated conditions as well. And again, this is a framework for what we do, but everybody is individualized. And each patient, we individualize how often we're seeing, how often we're getting certain testing and follow-up for. And I've mentioned this a few times before, but I'm just going to show it. So this is a spirometry, which is a part of the lung function testing series. And that's where we plug your nose and we ask you to take a deep breath in and blow out. And what we're looking for there in interstitial, there's a lot of different parameters we look at there, but in particular in interstitial lung disease is this forced vital capacity. And I mentioned that when we looked at those clinical trial results before. And what that is essentially how much air are you getting in on the inhale that then you're exhaling out. So it's right here on that line, the forced vital capacity. And so that's what we're monitoring very closely. There are other parameters we monitor as well when we're following people with pulmonary fibrosis, but this is one of the main things that we look at is lung function in the lung function testing. I mentioned this a little bit at the start, but just kind of segueing into monitoring into progression, right? So why are we monitoring? We're often monitoring to see that people are doing well on their treatment plan and looking for signs of progression. And so some ILDs, unfortunately, despite management, will progress even with treatment. And these are what we call the progressive fibrotic types. So there's pulmonary fibrosis, and then you add another P in front of it. Progressive pulmonary fibrosis, that's the term that's used most commonly now in the ILD world. And so it's a subset of people that have pulmonary fibrosis. And oftentimes we cannot predict, who will be the person that has a rapid progression, a slower progression, or be stable for longer. There's a lot of research going on right now to help identify ways to be able to predict that better. And so hopefully we'll have some of those tools in the future. But certainly there's different trajectories that people can take. And we monitor people very closely to look for signs of progression. And here are all of the causes of pulmonary fibrosis. Sorry, I didn't click on this before, that can progress. And I think I've mentioned this already before, but just to give it the idea in a schematic. So progression of the disease can be detected in different ways. And this is just a reiteration of what I showed before. When we see people in the office, so we're looking for increase in symptoms or change in symptoms, worsening disease on the CAT scan or the pictures of the lungs that we take, and decreased lung function, right? Or I showed you the lung function testing, the picture that patient having the lung function testing. And these are all things that we look for. It's never one thing that we rely on. We really look for at least two of these things when we're looking for progression. And this is based on a recent guideline that was published a couple of years ago, an update in how we look for and define progression. And a bunch of experts put together, a couple people at our center actually put together these recommendations. And so progressive pulmonary fibrosis happens in a patient who has ILD, right, of a known cause or an unknown cause, who has evidence of progression on a CT, and at least two of the following things happen with no other explanation, right? So worsening respiratory symptoms that we can't explain by something else, for example, heart disease or another cause of worsening respiratory symptoms. what we call physiologic evidence of disease progression. So that is lung function testing. That's a fancy term for lung function testing. So a decrease in that vital capacity, or another test that we look at, which is called the diffusion, people may have heard of, which looks at the way the oxygen transfers back and forth between the blood vessels and the lung tissues. And then, as I mentioned, radiographic evidence of disease progression, and that is changes on a CT scan. And we always look at the CT scan, and X-ray is not sufficient in that case. How does this impact the diagnosis, right? So the progression of things. And so sometimes it can help us to potentially, if we have a diagnosis, it sometimes may help have us, we may revisit the cause of that lung disease. Always we're trying to treat the underlying interstitial lung disease. We are monitoring for disease progression. And if there is progression, we're looking to evaluate the reasons why. Is it something that we can impact in the environment, for example? Is it somebody's autoimmune disease that may be worsening? And so we try to come up with the reason why. And if there is progression, we're always talking about what to do next. For example, if somebody has progressive scarring, do they now qualify for an anti-scarring or anti-fibrotic medicine that maybe they were not on before? So that sort of sums up all of those kind of areas that I wanted to talk about in this not so long period of time, but hopefully I was able to give you an overview. I think you could give a lecture on each one of these pieces of information, but hopefully I was able to give somewhat of an overview. And next, I want to talk a little bit about clinical trials. So, we talked a lot about current options for diagnosis and treatment, but we also are really thinking about the future with interstitial lung disease. And there's really some very exciting research that's happening that we're very hopeful will benefit our patients in the future. And this is very focused, what I'm talking about here, on clinical trials, but there are also a lot of studies where we're following people over time, over months and years, who have interstitial lung disease and pulmonary fibrosis, to see what different risk factors are for progression, and or how we can maybe diagnose people earlier, right, with earlier disease, to how to screen people for earlier disease. So we're learning a lot more about how to handle this as time goes on. In particular with clinical trials, so there are many studies in different phases of drug development looking at treatments for interstitial lung disease and pulmonary fibrosis. So I wanted to highlight some of them, ones going on at Cornell. This is not an exhaustive list because there are obviously studies going on at other centers as well. But we have several studies here. This is the EGCG study. So this is a study of green tea extract in patients who have idiopathic pulmonary fibrosis. And it's essentially a randomized trial looking at how this medication works in people with idiopathic pulmonary fibrosis and the safety of it as well. And right now, enrollment has paused because we did so great in the first phase enrolling, but we will be enrolling in a phase 2, hopefully to open at some point soon. There's another medication trial we have here for idiopathic pulmonary fibrosis, looking at another medicine that we're currently enrolling. And then this study, the Precision study, we actually just finished enrolling. It's a 24-month or 2-year study that people with, again, idiopathic pulmonary fibrosis were enrolled in, looking at a medication called N-acetylcysteine, which is a very common medicine that's been used for to treat other diseases. It's like available in a generic form, and it would be very exciting if this medicine shows promise with the results. So hopefully more to hear in the coming months and year about that medication. And then just continuing on for progressive pulmonary fibrosis. So these are non-idiopathic pulmonary fibrosis causes of pulmonary fibrosis. We have 2 inhaled medication studies that we're enrolling right now. One is an inhaled pirfenidone. So we may have heard of pirfenidone or Esbriet in the pill form. This is an inhaled version. And then there's another medicine looking at Tyvaso, again, inhaled. This is the medication that I talked about that we can use to treat pulmonary hypertension. Now we're also looking to see how it has an effect on progression of pulmonary fibrosis itself. So those 2 trials are currently enrolling here at Cornell. And then we have another, I'll skip to the bottom, another trial that I'm conducting in hypersensitivity pneumonitis, which is a kind of interstitial lung disease that's caused by inhaling something in the environment. And we are doing a randomized controlled trial of a peer-delivered intervention to help improve quality of life and knowledge about the disease. So we're currently enrolling for that. And then we have a biobank, a pulmonary and critical care biobank. I mentioned, aside from just clinical trials, we're also, as a community, really trying to better understand pulmonary fibrosis and risk factors and prognosis and progression. And so we are following people here at Cornell in a biobank, and we're currently enrolling for that as well. That asks people to enroll and take some medical information and a blood sample, and asks people to fill out some surveys about different experiences they have living with the interstitial lung disease. And this is the contact information for our research team. We have several research coordinators, and so they can be contacted at any time if you have questions about any of these clinical trials or are interested. Of course, you can ask your doctor. That is probably number one, to see if they think that you would be qualified or be a good candidate for any clinical trials. And then one last thing to sort of end. I'm so glad we were able to do this talk, and I think we need more of this. And there's been studies that have actually shown that online information about pulmonary fibrosis, when you just Google, for example, can be incomplete, inaccurate, and outdated. And there's been several studies that have shown this in terms of like how often the website is updated, how accurate the information is. And so, we really try to recommend verified resources to our patients for education. So the patient education resources, our center is clearly one good place. And then nationally, the Pulmonary Fibrosis Foundation, who I work closely with on different projects, is also a great resource for people in terms of education. So there's when you go to their website, there's a little understanding PDF, and they'll go into way more detail about all the things that I was able to talk about today. They have reading information for a lot of these different things. And there's information for patients' family members and caregivers. And there's also information on different research that's ongoing. There's a clinical trial finder. And then they also have their own registry. It's a community registry where you can just enter your information online and join that registry. And so, there's a lot of good resources. They have an oxygen support hotline. They also have patient support groups across the country, and a lot of these are online. And so there's different ways to get involved and find support through peers if that's something people are interested in. And then we have our interstitial lung disease program here at Cornell. Here are our doctors and our amazing nurse practitioner, Emily, and we have another nurse practitioner starting very soon, Brittany. And so, we are very, very dedicated to improving the lives of our patients who have interstitial lung disease. And so I'm so glad that I was able to speak with you today and provide this information. And this is just our group of us at the Pulmonary Fibrosis Foundation walk, where we walk to raise money for the foundation. So again, I want to thank you all for your time, and I will stop there and allow for questions.